Hello, I'm Dr. Jim Epstein, and welcome to Best of the Day from the Chemotherapy Foundation Symposium in snowy New York City. This is the 30th meeting of the Chemotherapy Foundation Symposium, begun back in 1972 by Dr. Ezra Greenspan, who passed away in 2004. And so this meeting is now held in memory of Dr. Greenspan and all the tremendous work he did. So this year we're meeting with a number of experts to discuss some of the material that's presented at this year's meeting. And this evening, Dr. Joanna Bendel from the Sarah Cannon Cancer Research Institute is with us, and we're going to talk a little about GI malignancy. So Joanna, welcome to Best of the Day.
Thank you so much for having me.
Well, thanks so much for coming. So it was an interesting session this morning. It was this afternoon. It was all heme this morning and all GI this afternoon, and there were a number of substitutions in there because of the weather.
Yes.
Where we're having a nor'easter here in New York. But some interesting discussions, and I want to begin by talking about angiogenesis. I mean, colorectal cancer is one of several diseases in which anti-VEGF agents seem to have found a mark. There's been activity in colorectal cancer and in renal cell and ovary and I guess in gliomas, but it's just fallen flat in prostate and pancreas and a number of other diseases. So talk a little bit about some of the data that was discussed regarding not only bevacizumab but aflibercept, and then some of the multi-targeted TKIs and what the potential role for VEGFR targeted TKIs are. We all remember Vitalinib failed a number of years ago, but there are a whole bunch of other more specific VEGFR TKIs like pazopanib and axitinib that have activity in other diseases. So what is the potential there? So let's begin with some of the discussion about BRIGHT and TML and the beyond progression use of BEV.
So it's interesting. I think what we're starting to learn for colorectal cancer is something that we've seen circumstantial evidence of for the last few years. And this all started with the 966 study, which looked at using bevacizumab in combination with oxaliplatin-based chemotherapy in the first-line setting. In this study, patients were randomized to oxaliplatin-based chemotherapy plus or minus bevacizumab. And what they found from this study was that there was a statistically significant improvement in progression-free survival for the overall population when you added bevacizumab to chemotherapy, but it wasn't as much as we were used to seeing. And what we started to see with that particular trial was when you broke it down into patients who were being treated until they had disease progression, you actually saw a much better improvement adding bevacizumab to chemotherapy. In that particular study, about half the patients were treated until disease progression, and half the patients came off early for reasons other than progression. And so that got a lot of folks thinking, do you get the best benefit from bevacizumab by continuing it until disease progression and potentially beyond? Because if you think of the potential mechanisms of action of bevacizumab, including vascular pruning, stopping tumor angiogenesis, do tumors become resistant to bevacizumab, or are they becoming just resistant to the chemotherapy? And so this was taken a step further with the two registry studies, the BRIGHT study and the ARIES study. Both of them 2,000 patient registry studies that just looked at how bevacizumab was being given, mostly in the community setting, and then trying to look back at what kind of data interpretation could they do. And the first report that came out of it was the BRIGHT study that looked at bevacizumab beyond progression. And what they saw was a very significant improvement in overall survival for patients who continued bevacizumab on beyond progression compared to those who didn't. And interestingly enough, the ARIES study showed the exact same thing. Now, all the biases that may be from looking at registry studies rather than prospective clinical trials, it was hypothesis generating. And what we were waiting for was data from the TML trial to come out. And this is the first study that actually looked at continuing bevacizumab beyond progression into the second line setting in a prospective randomized fashion. And we saw this data originally presented at ASCO this past year. And they took patients with either chemotherapy backbone of oxaliplatin and irinotecan, but they had bevacizumab in the first-line setting, and then randomized them to the alternate chemotherapy and continuing or not continuing bevacizumab. And what we saw is that there was a statistically significant improvement in overall survival for the patients who continued bevacizumab beyond progression. Now, that improvement was about 6 weeks with a hazard ratio of 0.8. Not the extent that we saw in the ARIES or BRIGHT studies, but it was an improvement. And what it's suggesting, at least in my interpretation of this data, is that there is a population of patients out there who should continue bevacizumab beyond progression. The question is, who are those patients? And I think biomarker studies are the only things that are going to give us the answer to who those folks really are.
So do VEGF levels, or microvessel density, or other markers give us any hints as to which patients are going to or did get the best results? If you look back retrospectively at the group that got the best benefit as opposed to those who didn't, can you identify any factors that are prognostic or predictive?
Right now, we don't have any solid leads. We have some soft leads, including things like HIF-1 alpha levels. But I think right now, there's still a wide open field that's really trying to interpret who these folks are. Now, the MD Anderson published results of a very interesting study of 50 patients who received FOLFIRI plus bevacizumab as first-line treatment for their metastatic colorectal cancer. And what they did is they took blood-based biomarkers. They looked at cytokine levels, pre-treatment, on treatment, and then at progression. Now, we always have to interpret this study data with a little bit of a grain of salt, but what they did see is that FGF, fibroblast growth factor levels, as well as HGF, so hepatocyte growth factor levels, did seem to increase at progression of disease. Also, PLGF, placental growth factor, seemed to increase at progression of disease. So were these potential markers of development of resistance? Hard to say, but these have become the focus of maybe other targeted agents, which we'll talk about momentarily, that could serve as agents that might help people become sensitized to anti-angiogenic agents.
So, and could they tell if these marker increases or overexpression were secondary to failure of the chemotherapy or failure of the anti-angiogenic agents?
That's the problem that we don't know.
Very good.
Yeah.
So what about aflibercept? The Valor trial was presented a year or so ago, and aflibercept has now been FDA approved. There's been some controversy, articles in the Wall Street Journal and other places about cost, but this is an alternative, and I'm sure people in practice are thinking, well, should I go with bevacizumab in the second line, or should I switch to aflibercept and then go back to bevacizumab? Right. What's the story with this agent?
So when you look at the Valor trial, they took patients who had progressed past first-line therapy. Now, patients could have received bevacizumab. They didn't have to receive bevacizumab. About a third of the patients on that trial ended up having bevacizumab in the first-line setting. And what they saw was when you used aflibercept plus chemotherapy versus chemotherapy plus placebo in the second-line setting, there was a statistically significant improvement in overall survival in the overall population. And it, very interestingly, it was right along the lines of what they saw for TML, an improvement in overall survival by 6 weeks and a hazard ratio of 0.8. So when you look at the data head-to-head cross-comparing the two trials, they seem to show equivalent improvements in overall survival. Now, the one interesting thing about aflibercept is it was designed as a fusion protein that binds to not only VEGF-A, just like bevacizumab does, but it binds to VEGF-B as well as placental growth factor, PLGF. Now, we were hoping that potentially aflibercept would show us an even better improvement in overall survival because it hit these extra targets, but it doesn't seem to translate into one at the moment. So what people are looking at right now is, I think, one, their comfort level with the agent and how they feel. A lot of people have a lot of experience with bevacizumab, so they may continue bevacizumab because it's an agent they know. There's been some discussion looking at the side effect profiles of the two agents, looking at FOLFIRI plus bevacizumab versus FOLFIRI plus aflibercept. When you look at the aflibercept data, aflibercept seems to have a little bit more toxicity in terms of neutropenia, diarrhea, asthenia, and stomatitis than bevacizumab does historically. So that different side effect profile may influence people's choices. The cost, of course, of the agent may influence people's choices. I think that in the second-line setting, the data is probably equivalent in terms of improvement in outcomes with either agent, so you could pick either or, and I think it's really going to come down to a decision of comfort with the agent, side effect profile, and then cost.
Right. Is aflibercept going to be compared with bevacizumab in the front line?
So when you look at the frontline data, there was a randomized phase 2 study that's been performed looking at the addition of aflibercept to oxaliplatin-based chemotherapy. Now, it was a randomized phase 2 study and showed no improvement in outcomes adding aflibercept in that randomized phase 2. But I think there is potential for looking, and they are going to look in a randomized phase 3 study at aflibercept in the first-line setting in combination with oxaliplatin-based chemotherapy. So hopefully we'll see some data from that in the
That'll
future.
be interesting. And so what about the TKIs in anti-angiogenic programs for colorectal cancer? As I mentioned, betalanib failed.
Yeah.
What about some of the other agents, and even regorafenib has some anti-VEGFR activity. So what is going on in that area?
Well, I think the issue with the VEGFR TKIs is that they hit a lot of things besides VEGF. And so when you hit a lot of things besides VEGF, you have increased potential for efficacy because you're hitting other targets, but you also have increased potential for toxicity. And when you look at the toxicity profiles of VEGFR TKIs compared to, for instance, bevacizumab, you tend to see a lot more fatigue, the hand-foot syndrome, potentially diarrhea, potentially stomatitis. And I think that when you look at the data of other VEGFR TKIs that have been used in trials with metastatic colorectal cancer, most of them have been in combination with chemotherapy. And I think what we've seen from sunitinib studies, from axitinib studies, from cediranib studies, from betalanib studies, is that the addition of that VEGFR tyrosine kinase inhibitor to chemotherapy causes more toxicity and probably causes people to not get as much chemotherapy intensity or VEGFR TKI intensity as they would if they had it as a single agent. So what I think is very interesting about the regorafenib data is this was looking at regorafenib as a single agent versus placebo. And so in my heart of hearts, and this is just my own gut instinct, no pun intended, that I think that the problem with VEGFR TKIs is the toxicity profile and the toxicity in combination with chemotherapy. Not that they aren't potentially effective for patients. And so when you look at that regorafenib data showing an improvement in overall survival in the refractory setting, 6 weeks again, hazard ratio 0.8, where I think that leads us is not only to an agent that could potentially help us in terms of refractory colorectal cancer patients, but when you think of things like maintenance therapies, in the first-line setting, most patients go onto some sort of maintenance therapy, whether it be at physician or patient request. And could VEGFR TKIs as single agents that are oral, save chair time, save potentially doctor's offices trips, could that be a maintenance agent, a new development pathway for VEGFR TKIs in the future? So I think that we're opening a door, but we're also learning that the power of VEGFR TKIs is probably going to come more from single agent use than combination.
But we all remember what happened with the colorectal trial with adjuvant bevacizumab in a state of minimal disease burden. So whether or not that would work, I guess, is still up in the air.
Exactly. And is there that difference between micrometastatic disease and metastatic maintenance? And it's hard to say.
Very good. Well, let's move on briefly and talk about hepatocellular carcinoma. Andy Zhu gave a very nice review of what's going on in that disease. And we've seen that sorafenib is still the standard of care. Right. It's been compared with other agents, including sunitinib, and it just seemed like the toxicity was worse and the benefit no greater. What is the thrust of clinical research in hepatocellular carcinoma now?
I think it's a very difficult disease to study. One, because it's rarer within the United States. Two, because the epidemiology is so different in the Western world versus the Eastern world. Is it being caused by hepatitis B, hepatitis C? Is it being caused by alcoholic cirrhosis or other types of cirrhosis? So I think that makes it much more difficult to interpret studies that have to be done globally to be able to get the accrual. I think people are still continuing to look into anti-angiogenic mechanisms of action for drugs, but I think what's more interesting is people are trying to branch out now, and they're starting to look at more of these targeted agents. And I think that Andy showed some very nice data, was looking, for instance, at c-Met. And so we've seen recent data from tivantinib, which is a c-Met inhibitor. And it was a second-line hepatocellular cancer looking at tivantinib versus best supportive care, and saw an improvement, particularly in c-Met overexpressing liver tumors in terms of progression-free and overall survival. And this is being taken forward into a randomized phase 3 study. But I think where the thrust is going now is branching out outside of just angiogenesis inhibitors, and also the potential of combining angiogenesis inhibitors with other targeted agents. People are still awaiting data looking at everolimus, an mTOR inhibitor, for patients with hepatocellular cancer. So hopefully we'll see some data on that coming soon. I think there's a second-line study that's ready to read relatively quickly.
So is c-Met overexpression common in hepatocellular carcinoma?
You can probably see it in about 30 to 40%. That's about where c-Met runs, and this is looking at it by immunohistochemistry analysis. And so hopefully what we'll start to see, just like we did with the tivantinib data, is that that specific subset might have a new agent that could benefit them.
What about targeting the ligand?
So you can also target HGF. So the c-Met pathway is made up of the c-Met receptor, which is the receptor that sits on the outside of the cell, but HGF, hepatocyte growth factor, is the ligand that binds to c-Met to activate it. And so there's other agents in development out there that target the ligand. Specifically, one is called rilotumumab, or AMG 102, which binds to HGF. Now, we haven't seen data come out from that agent, particularly in hepatocellular carcinoma, but we did see some data from that agent in gastric cancers, where we saw an improvement in progression-free and overall survival in a randomized phase 2 study in the c-Met high population for gastric cancers using that agent.
What about the METMAB drug, or narsatuzumab, or whatever it's called?
Oh, yeah.
Very long name, as I recall.
I call it the one-armed man. So
Yeah.
what it is it is a one-armed antibody that binds to the MET receptor. So we have tivantinib that's hitting the tyrosine kinase of the MET receptor. We have onzartuzumab, now you got me saying it, or METMAB, which is hitting the outside of the antibody, the extracellular part of the antibody. And then we have AMG 102, or rilotumumab, which is hitting the ligand. We've seen great promising data of METMAB for metastatic non-small cell lung cancer. We're also starting to look at it now for metastatic colorectal cancer. We recently completed accrual to a randomized phase 2 first-line study in combination with FOLFOX plus bevacizumab. So hopefully we'll start to see that agent come through as well.
So as long as we're talking about MET, you gave a very nice overview of the MET pathway. So let's talk a little bit about that. I mean, everyone's familiar with the HER family, the
Yes.
EGFR, HER2, HER3, HER4, with the MAP kinase pathway and the PI3 kinase AKT-mTOR pathway. MET is another surface, cell surface RTK. Is MET commonly expressed de novo in a lot of malignancies, or is it overexpressed as an escape mechanism or survival? We see in EGFR mutant non-small cell lung cancer, most of the resistance there is a second mutation in the EGFR gene, but about 20% are MET overexpression. So is this escape mechanism common, or is MET the primary oncogenic driver in a number of malignancies?
I think you're going to get an answer that, and the answer I'm going to give you is that it's probably a lot of Both. We've seen multiple ways that the MET pathway can be activated within cancer. So we can have direct mutation of the receptor, we can have overexpression of the receptor, we can have increased expression of the ligand to activate the receptor. It's not known whether or not it's a reactive phenomenon, whether with treatment do you start expressing more and more MET, though one would think that that would be a very potential escape mechanism. But I don't know that anybody's done the serial biopsies to look at upregulation with treatment. But what we do see is that it does contribute probably in some way to oncogenesis, whether it's the primary driving factor or not. We've seen overexpression of MET in about 40 to 50% of multiple types of tumors: non-small cell lung cancer, triple negative breast cancer, colon cancer, gastric cancer. So it really, we're seeing a lot of cancers that are involved with MET overexpression, which is why you see such a development pathway for MET inhibitors or MET pathway inhibitors across multiple tumor types. What MET does is when MET is turned on, it can be turned on its own, or it can form heterodimers with other receptors on the cell surface, and most famous of which would be the HER2 family, HER1 family. So EGFR and MET will heterodimerize and then send signals for proliferation downstream from there. The MET pathway does still use the PI3 kinase pathway, et cetera, to send that downstream signal down to the nucleus to tell the cell to replicate. We've also seen MET levels upregulated, as we mentioned earlier, for instance, in response to anti-angiogenic therapy. And we've seen in preclinical models that giving HGF or inhibiting VEGF will drive up HGF levels to turn on MET as an escape mechanism to help turn angiogenesis back on.
Interesting, because HGF is made by mesenchymal cells, whereas c-MET is on epithelial cells. So
Exactly.
it's a different sort of system. Well, it'll be interesting to see how some of these agents, METMAB and rilotumumab and tuvantinib and some of the other MET inhibitors progress. Be an interesting year ahead.
Yes, full of promise.
Well, let's go on and finish up with gastric cancer and gastroesophageal junction cancer. David Olson always does a fantastic job of covering the data, and his topic today was beyond HER2 beyond trastuzumab, and we already know that pertuzumab has been approved in breast cancer, and the TDM1 agent loaded with a bomb is undoubtedly going to get approved for breast cancer before long. What all did David cover, and what seems to be the direction that these targeted agents are headed in upper GI malignancies?
Well, I think one of the exciting things is that for HER2 positive esophagogastric cancers, we already have a track we can follow, which is the breast cancer track. And we've seen from all the breast cancer studies that have been done looking at how to attack HER2 in HER2 positive breast cancer patients, we're now starting to follow that track for esophagogastric cancer patients that overexpress HER2. And so that development path of looking at pertuzumab, which hits HER2 plus HER3. And we know that HER2 and HER3 heterodimers are very strong signal activators to cause cell growth in HER2 positive tumors. And so hitting them both, just like in breast cancer, we're hoping in gastric cancer will be much more effective than just hitting HER2 alone. Same thing with lapatinib, hitting the HER2 receptor internally from the tyrosine kinase. Or can we do even better by hitting Herceptin plus lapatinib or trastuzumab plus lapatinib and get more effective HER2 blockade? We also are looking at TDM1. TDM1 is a fantastic drug for HER2 positive breast cancer patients. So you've got the trastuzumab that's bound to the MMAE, the mysantine cytotoxic bomb, right, and does direct tumor delivery. And so there'll be a second line study that's going on looking at TDM1 versus Taxol or paclitaxel for patients with HER2 positive gastroesophageal cancer.
So the trastuzumab has to be internalized, and then the MMAE is released.
Exactly. Exactly. And so there is some, the side effect profile of TDM1, you do see some breakage of the linker between the Herceptin and the trastuzumab and the MMAE, which causes some side effects, but nothing compared to what MMAE would do if it was not linked and directly given to a tumor
It's
cell.
pretty toxic when used by itself.
Exactly, exactly. Intolerable, in fact, when used by itself.
Very good.
So we're also looking at pertuzumab in the first-line setting, so chemotherapy plus Herceptin plus or minus pertuzumab. And there's also another pan-HER tyrosine kinase inhibitor blocker, afatinib, which David mentioned they're looking at in a clinical trial at Memorial Sloan Kettering as well.
Yeah, afatinib is being looked at extensively in non-small cell lung cancer and also in head and neck and a variety of other diseases, and irreversible pan-HER binder. So that's very interesting. Anything else new? We know that bevacizumab failed in combination with chemotherapy and gastric cancer. Is there any work being done with VEGFR targeted agents there?
Absolutely, positively. So when you look at the AVAGAS trial, this was the bevacizumab worldwide randomized phase 3 study, chemotherapy plus minus bevacizumab. The very interesting part is though the overall survival for the trial was negative, or no statistically significant improvement, when you break it down by region of the world where patients were treated, when you look at the Western world, there seemed to be a very significant improvement, I think a hazard ratio of 0.6. And so following that pathway, we've recently seen a press release from ImClone, which has looked at its drug, ImClone Lilly, which has looked at its drug,
Is that the ramucirumab?
Ramucirumab. And this was second-line ramucirumab versus placebo for metastatic gastric cancer. And actually, they press released that it did meet its primary endpoint of overall survival improvement using ramucirumab as a single agent versus placebo for second-line gastric cancer.
So and this is a monoclonal antibody to the receptor as opposed to VEGF.
Correct, to VEGFR2. And so that was very exciting to see. And ramucirumab also has recently completed accrual to a randomized phase 2 trial in the first-line setting of FOLFOX plus or minus ramucirumab for patients with esophagogastric cancer.
Very interesting. All right, that's great. Well, Joanna, thank you so much for coming by and going over all of this with us. It sounds like things are really gearing up in GI malignancies. I think the critical thing is to identify these biomarkers which will predict which patients and which groups of patients are going to get the greatest benefit from which targeted agents. That's going to be the key.
That's very true.
Absolutely. Well, thanks again, and thanks to all of you for watching this segment of Best of the Day from the 30th meeting of the Chemotherapy Foundation Symposium held this year in snowy New York City. Thanks again.